I am Tabitha Hendershot from RTI International. I am the principal investigator for the Sickle Cell Disease Implementation Consortium Registry, also known as the SCDIC. In my presentation today, I'll describe the two SCDIC registries and the natural history data resource, as well as the resulting longitudinal data that's being collected and available in Biodata Catalyst. So the SCDIC there are two registries. The first one was funded by NHLBI from August of 2016 through June 2023. 8 treatment centers across the US participated, along with RTI as the data coordinating center. There were 3 components. The first was a needs assessment study to understand barriers to care. There were implementation research studies to address barriers to care and to understand why some patients become unaffiliated from specialty care. And the third component, and the one I'll be discussing today, is the establishment of a longitudinal registry of 2,400 patients to understand the natural history of sickle cell disease. During the 18 months between 2017 and 2018, 2,440 people signed consent to participate. And at that point, we collected baseline clinical data as well as survey data. Most of the people that we enrolled at the clinic were at the clinic, receiving care at the clinic at which they were enrolled. And this existing relationship between the patient and the clinic is an important component of the registry, allowing for the success of long-term follow-up. So over the next several years, participants completed an annual follow-up survey. We also collected clinical data from patient medical records a second time. In the meantime, NHLBI realized a need to identify a cohort of well-characterized patients to serve as comparator groups for gene therapy or other clinical trials, or for comparative effectiveness studies. So with those grants that supported the first SCDIC coming to an end, NHLBI recognized the value of the SCDIC registry and the opportunity to continue it under the Cure Sickle Cell initiative. As an established registry with an existing data platform and infrastructure, the SCDIC became the basis for the new Natural History Data Resource, or NHDR. Data standardization was an important component of developing the NHDR. We updated the SCDIC clinical forms and patient-reported outcome survey to include all of the core common data elements recommended by the CureSC working groups in March of 21. And this use of the core CDEs makes it easier for data from multiple studies to be combined for meta-analysis. We also had a goal to extract structured data from EHRs when possible. To enhance the population of pediatric and young adults in the NHDR, we worked closely with Granddad leadership to harmonize the data collected across our 2 registries and then integrate their data from about 100 of their participants. And the final component of the NHDR is sharing the de-identified data through Biodata Catalyst. So picking up the timeline again, we continued the new and improved SCDIC2 under the NHDR umbrella. Between 2022 and 23, we consented 1,220 of those who participated in SCDIC1. So we got a lot of those people to continue on into the second registry and resumed that annual follow-up with those folks. We also enrolled 450 new people to the registry, collecting baseline clinical data then and survey data at that point of enrollment, and then doing an annual follow-up. So we ended up with in SCDIC2 with data from over 1,600 people. This flowchart shows how data moves from the sites to the data coordinating center and finally to Biodata Catalyst. At the study site, coordinators abstract data from patient medical records and then enter the data into REDCap. Patients complete their annual surveys directly in REDCap on an iPad at the clinic or online. They have an online option, so they can do it from their own device. We receive data from Grandad as well, after which we run edits on all the data, resolve discrepancies before going through the final curation and de-identification process. And then we send that data on to Biodata Catalyst. And this will, we've done it once so far, this will occur on an annual basis going forward. So here's some information about the two registries side by side. In terms of the eligibility criteria, people in both registries had to have a confirmed sickle cell diagnosis, had to be English speaking, and provide signed informed consent to share data. In the first registry, we enrolled people who were 15 to 45 years of age at the time of enrollment, while people in SCDIC2 had to be at least 14, but there was no upper age limit. The availability of a medical record was really critical to the SCDIC2 to support data collection in the long term. The difference with SCDIC1 is that we were interested in enrolling people who were unaffiliated, so medical record availability wasn't required for that, that phase. This shows the type of data and the frequency of data collection across the two SCDIC phases. The purple box here represents when people were consented. So people who continued from SCDIC1 had to be reconsented as part of SCDIC2. The medical record abstraction, recent labs, and healthcare utilization forms represented here were collected at enrollment in phase 1 and a second time towards the end. In phase 2, we collect these same data annually. You'll see here, along with a new procedures form represented in blue and a cardiac procedures form. You can see here too that the survey with PROs represented in yellow is completed annually throughout the two phases. So for the 1,200 people who continued from phase 1 to phase 2, we have 8+ years of data. And for the 450 people who were enrolled in phase 2, only we have 2+ years of data. Because this is an observational registry and there's not a specific study visit, the data that we collect is not necessarily aligned. So for example, a person may complete a survey independent of when labs were done. Now I'll describe the forms. The laboratory form is quite extensive. It includes the most recent lab results for 50 tests. Healthcare utilization captures visits to various providers as well as to the hospital, ED, pain center, and transfusion visits. The procedures form collects information about liver biopsy or MRI, as well as cardiac, brain, and spleen imaging. For those people who had a cardiac procedure, the cardiac procedures form collects additional details about those procedures, like an echo, EKG, or catheterization. So I sort of touched on this already, but because the SCDIC1 was a research driven project, those forms were really designed to be able to answer research questions. For SCDIC2, we tried to maintain a lot of the continuity in the forms, but also simplify them a bit so that they're easier to complete, and also to make sure that we include those core NHLBI SCD data elements. This slide lists specific items collected on both the clinical abstraction form on the left and the patient survey on the right. The main medical record abstraction form includes a lot of clinical data, including diagnosis, visit history, transfusion history, comorbidities, and medication. The first time this form is completed, we collect data on events that have ever occurred, so it really covers a wide range of the person's medical history. For the annual patient survey here on the right, it includes information about pain, cognition, sleep, depression, barriers to care, comorbidities, and medication use. You can see here that the use of existing instruments to collect data in a standard way to facilitate cross-study analysis. And while we encourage completion of the patient survey, it is optional. People have other things going on in their life, so they may not complete this. We don't really expect annual compliance, but you'll see that we do have PROs across many years. So this slide, I wanted to give you a sense of the longitudinal data that's available by form type. So we have nearly 1,000 people here with at least 4 surveys with patient-reported outcomes. And then we have over 1,000 people with at least 4 abstraction forms with the clinical data and with the recent laboratory data. So this really is a very rich resource of clinical and patient-reported outcomes. This is some descriptive information about the 2 registries. Because 2/3 of the people are represented in both registries, the data is quite similar. Overall, we've enrolled more females than males. We've got a mean age for people in the second registry of 32 years. About 5% of both groups are Hispanic. Nearly 70% of people have hemoglobin SS, 20% have hemoglobin SC, and around 10% have hemoglobin beta thalassemia. At the time of consent, just over 50% has a household income of less than $25,000. We had 75% and 69% of people that were on Medicare or Medicaid, and 41% and 37% were employed at the time of enrollment. I'm going to switch here to the website. This is the URL for the NHDR website. We're actually in the process of standing up this site now. So while the URL that you see here is active and represents the metadata catalog that Helen will talk about, and that I'll come back to in a second, the NHDR component will be available shortly. But I just wanted to show you the navigation here on the page. So if you click on this data sharing button here, it'll take you to this the data sharing page, and if you scroll down to the bottom, you'll have a link here that takes you directly to Biodata Catalyst. And when you get to Biodata Catalyst and click on the keywords in the study names, if you search for the SCD NHDR, that will pull up the data that's available in Biodata Catalyst now. Currently, BDC includes data for the 1,670 people enrolled in the second registry. BDC is in the process of adding the granddad data that I mentioned, has about 100 people. And then the SCDIC phase 1 data is currently in BioLink and will eventually be transferred to Biodata Catalyst. I want to mention that the data between the SCDIC 1 and 2 is linked with consistent variable naming to facilitate data analysis. This is our web-based metadata catalog, or MDC, that I mentioned, and that Allison mentioned too. It is a publicly available web-based tool that provides metadata on 27 clinical SCD studies, including the SCDIC. It can help answer questions like what data elements were collected by the studies and which data elements are common among studies. Coming here is a really good first step to understand the types of data that were collected before requesting access to controlled data sets. Finally, I want to thank our teams here at RTI. On the left are those involved with the SCDIC registries and the NHDR, folks that have been part of the infrastructure from the beginning that have really helped with the continuity of the projects. And the metadata catalog is led by Helen Pan with support from her great team on the bioinformatics side of our work.